This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host Leslie Odell. And we are super excited to be talking all about allergy. There's such extensive overlap between allergy and dry eye. And so we brought in our favorite allergy expert, Dr. Milton M. So Dr. M practices in Azusa, California. Dr. M's a scientific fellow of the American College of Asthma, Allergy, and Immunology. He's an internationally recognized expert and researcher in therapeutics, dry eye, presbyopia, contact lenses, and allergy. He is also co-medical director for the multi-site neurosensory abnormalities in systematic ocular surface patients study. And Dr. M has written 4 books and published over 200 papers and peer review abstracts. So I thought we could maybe kind of walk into allergies with kind of doing a nice overview on allergies and the overlap. I mean, this is a dry eye podcast, so we really have to, we couldn't really have a podcast without talking about dry eye, and allergies fit into that, I believe. So can I hear from you on your overview of allergies and how you feel that overlaps between dry eye?
Yeah, we did a study a few years ago with Len Bellori. He's a world famous allergist that's really concentrating a lot on allergic conjunctivitis. And, I got in a discussion with him about the overlap of allergy and dry eye. So we ended up doing a study and we found that, the overlap's over 50%. So it's almost like, if you just are looking just for one entity, you're going to miss the other one. I mean, the way I look at clinically is you got to look at both, and they're very, very similar.
I think that's a great point. And I feel like oftentimes I'm seeing a lot of similar clinical presentations, and maybe I should care less about if it's one or the other and think of it more like a possibility for the and approach. But does that change the way that you would manage those patients at all? Do you think less for topical or systemic antihistamines, for example, if you have a patient that has a high osmolarity?
All right. So, like I said, there's an overlap of 50 to 60%. And I'm beginning to think now that, you think about it, it's almost like, we're doing a lot of work with central and peripheral pain. And what we're finding is that, a lot of them are actually mixed components. So what I'm thinking now is that, you have an allergy component and then you also have a dry eye component. And one of them could be larger than the other. They could both be equal. And I think probably in terms of treatment is really relatively the same between the allergy and dry eye. You might want to bias if you think that allergies may be overwhelming at the time, maybe bias towards more allergy treatment, or maybe if the dry eye, MGD, so on and so forth, then you might want to go ahead and bias towards that direction. But usually, typically clinically, and I was talking to Jackie about this earlier, is that, if a patient comes in with dry eye, I assume that I also have allergy. And what I'll do is I'll prescribe both an antihistamine and a dry eye medication at the same time. And for most of the patients, I'd probably say 90% of the patients, it works. Of course, we have the other ones that don't work. And that's when you get into more of the specialty treatments and things like that. But, just simply giving both of them, treating both of them usually works pretty well for, me and my practice.
So, do you see that there's anything different clinically? I mean, I know in school we're taught, or we think, more allergies. We think this patient is going to be complaining of itchiness, but sometimes you'll see this sort of papillary response in patients that aren't itchy. Do you find certain clinical signs that you're looking for, or you're just sort of assuming you guys probably have both, and I'm just going to treat you both for the dry eye component and for the allergy component?
Jackie, I just love what you said because not all allergic conjunctivitis is itchy. Not all of it. I mean, how many times have you had patients that come in without itch, but it's obvious allergy? They're tearing, their eyes are red, you have got papillary response, you got all these things going on. Are you itchy? No, but you have allergies. So yeah, you you, you hit it right there. Um, you know, one thing that we started looking at, and Leslie will attest to this too, is that we started looking at car uncles. Now, how often do you look at a car uncle? Well, what we did was that we went ahead and put stain in there and took a look, and we found actually that car uncles have a papillary response, and it kind of stands to reason because when you have a lot of pollen in the air, it gets into the tears. So where does it drain? It drains right here. And where's your carbuncle? Right there. So really, we found that that's actually a clinical sign that the patient also has allergy.
I gotta say, I don't pay attention to the current call, but I'm gonna start actually. But I do find that a lot of my allergy patients have a lot more, even just conjunctival staining nasally, compared to other parts of their eye.
If you just move your slit lamp a tiny bit more nasally, you'll find that that kind of staining pattern comes right up into the caruncle. It was really interesting. The second part of that study, I think we disproved, but I was also convinced that those patients were growing more eyelashes in that area. So we were testing that too, but I think we did not prove that that had any relevance. So I actually will say that I've been looking much more at the caruncle for some of my dry eye patients, especially when they have like a foreign body sensation nasally or, now looking for the allergy.
What is your allergy eye drop of choice? What do you like?
Oh, so I mean, there's anti-muscarinic effects with antihistamines, and what's interesting is that I was presenting a paper at the College of Allergy, and I'm also a fellow there. And what happened was that I was standing right next to another allergist, and he was looking at my poster, and I was looking at his poster, and he was mentioning the fact that most of the allergy drops that we see now have been reversioned from allergy drops that are actually oral allergy drops. So oral allergy drops have been reversioned into eye drops so that we can use it in the eye. And he was mentioning that, an antihistamine is not worth its salt unless it has an extreme drying effect. It has to dry out. Antihistamines must dry out. Otherwise, they would never make it to market. And this is what we're talking about, nasal sprays. We're talking about oral antihistamines. It must have a drying effect. And really, when you take a look at most of the antihistamines that are out there, I'm talking about oral and also nasal, the reason why that the major indication is what? It's rhinitis. So it has to dry out the mucous membranes. If it doesn't dry out the mucous membranes, then it's not worth anything. So, what does that mean for the dry eye? What does that mean for the ocular surface? It means that they dry out the ocular surface also. Otherwise, they would have never made it to market. So, the drying effect is called the anti-muscarinic effect. And Wade went ahead and did a study, and he took a look at all the different antihistamines, especially the ones that we use for the eye. And to believe it or not, there is varying levels of dryness or varying levels of anti-muscarinic effects for different antihistamines. In fact, the antihistamines that are on the market today that we use, let's say for drops, they all have different drying effects. Probably the one that dries out the most is Optivar or azetalastine. That one is a generic available, but that has an extremely strong anti-muscarinic effect. The ones with really, really low anti-muscarinic effects are things that are called like epinastine, which is actually Elestat, or something like alcafidine, which is actually Lastacaf. So usually I bias more towards those drops that have lower anti muscarinic effects based on the fact that you don't want to have the antihistamine responsible for also inducing more dry eye, which is already there.
Do you think that for your patients that are kind of suffering from both, that if you have a certain amount of time, we see with flares we're maybe targeting these 2-week window. Are you thinking it? Are you thinking of it more like seasonality? If you have a patient that has spring allergies, for example, do you just say take this in addition to whatever you're doing for dry eye until the pollen counts go down or the things have bloomed, or what's your guidance there? Are you using symptoms, or I'm just curious about that.
So, okay, so you're talking about dry eye flares. Is that what you're talking
No,
about?
I'm saying when you have your allergy patient that you want to really dry up because they're having a lot of allergy, but they also might be a dry eye patient. Do you have a window that you do your overlap treatment? Is it normally it takes you 2 weeks or 4 weeks or whatever it, might take for you to break the cycle of the allergy, I guess, is what I'm wondering. Is it cyclical like that or not that you found?
Yeah, cromolyn also, and another drug called Alacril. What they found is that over 2 weeks, uh, the effect, the antihistamine effect, mast cell effect, so on and so forth, increases over a two week period. So yeah, I would say after 2 weeks is probably where I would, make. Yeah, I would probably give that kind of window. These antihistamine drugs, have you seen some of the clinical studies on them? I mean, it's not like, well, do they work like, in 1 week? No, no. Do they relieve itch like in 1 minute,
Yeah.
3 minutes, 5 minutes? That's what the data says. I mean, these things work extremely fast. So, when you talk about, what kind of event horizon you're talking about, I mean, I think 2 weeks is plenty of time that you're going to go ahead and see some sort of changes there.
So, when we have like a patient that has allergies, ocular allergies, let's say, I'm always asking them, are you also taking an oral antihistamine as well? If I'm battling both allergies and dry eye with this patient. And, sometimes if they are and they don't really need it for a systemic reason, they're taking it because they think it will help their eyes. And so I then encourage them to not do that. But let's say a patient has a lot of rhinitis and sinusitis with allergies. Is there a particular systemic allergy medication that is better for our dry eye patients? Or, as you were saying earlier, it really does just have to be a very drying medication for it to be effective?
There's something called antihistamine resistance. So what happens is that the histamine receptors actually will fatigue over time in terms of if you continually use antihistamines, especially with oral antihistamines. And they find that, allergists have also found that, in other conditions, more noticeably, like skin conditions, things like that. So basically what it is that my recommendation is that you should rotate your antihistamines. You should rotate your oral antihistamines because you do not want to have antihistamine resistance. So in other words, you can go ahead and you have them use Claritin. And then if after that, then after they go through the bottle of Claritin, go ahead and switch over to Allegra. After they do that, then go ahead and switch over to Zyrtec. So really, I think that more importantly than anything else is to rotate your oral antihistamines.
I've never heard of histamine receptor fatigue.
Yeah, yeah, yeah. It's something that allergists found because when you have like itchy rash and everything like that, urticaria or eutrichia, whatever that we like to call that, patients will have that. Allergy patients will have. Allergists will tell me, "Oh yeah, they'll have it for 10 years." So over the 10-year period, you're going to go ahead and keep blasting them with the same oral antihistamine or topical antihistamine? No, you're not going to do that. What you're going to do is that, and the reason why is because they found that you will get antihistamine resistance. So allergists know this.
I mean, that's definitely interesting to think about. And there's so much probably to learn from the systemic angle. What are the main triggers that you see for ocular allergies?
Well, okay, so you talk about dry eye, you talk about allergy. and you say that they're always related and the clinical signs are, well, the reason why is because the triggers are the same. The triggers are very, very similar. But not only that, but you also have asthma. Asthma also falls within that continuum. You have dry eye, you have allergy, and then you also have asthma. So all three of them, what do high pollen counts do? High pollen counts will trigger allergy. High pollen counts will trigger dry eye because Leslie, we've done studies on that, remember, with Jen Harthen and Claire Holloran. High pollen count would trigger dry eyes, and also high pollen count will also trigger asthma. What about high temperature? High temperature will trigger asthma. It will also trigger dry eye and will also trigger allergy. Humidity, the only difference in humidity is that low humidity would trigger dry eye, but high humidity will trigger allergy, and high humidity will also trigger asthma. So all these things all have the same kind of triggers. And you see, it's called the one airway. So what it is that airway is connected through the eye. This is all mucous membrane. So the way the allergists look at it is that the problem is that as eye doctors, we see it only as the eye, but allergists see this as one airway. They see it as one unit, and it's all connected together. It's the ocular surface connected through the eustachian tubes into the ears. You've got the sinuses, goes down into the nose, back of the throat, down into the lungs, which is asthma, correct? So what happens is that they see it as one unit. So what they say is that during that time, one part of that one airway may be more inflamed than the others, but they're all related. So you always have to think about treating them all the same, or treating, when you have one, then you're going to go ahead and treat the other.
This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
That's a good point. I have a question on, and you and I have talked about this offline before, but when you have a dry eye patient, we talked about the very high overlap between dry eye and allergies. Is your exam, are there certain, we kind of alluded to this before, but are there certain clinical signs that you're seeing that's going to make you, like you see a lot of obstruction in the glands, so then you lean more towards treating meibomian gland dysfunction? Or are you sort of like hey, I'm going to give everybody an allergy eye drop because I believe everybody has this? Even if you see no caruncle staining, no papillary response, are you still assuming that?
Yes, absolutely. Absolutely. Why are they coming in? Are they coming in because it's high pollen counts?
Maybe they're coming in because their meibomian glands are obstructed.
Is there a connection between meibomian glands and MGD and allergy? Yes.
I thought you were going to quiz her.
There's a connection. There's definitely a connection. There's literature that's showing that there is a connection between the two.
Well, I guess if you think about that, those studies that he was talking about, if the environment is triggering allergy and dry eye symptoms, right? It was triggering both, because we would have to look at the pollen count for our area in the day when we were asking the patients these questions, and that was part of it. So it's really kind of interesting to think about your eye. I mean, it's interesting to know that allergists are thinking about it as one continuous pathway. I don't know that I've really thought about it that way.
Well, it's because you're not an allergist. Okay, here's the tip. All right, so what it is that I have a patient come in, and they have allergy. All right, so this is high pollen count time. You know that this is an allergy. So this is what I'll tell the patient. I'll just say, do you know what you're allergic to? And they'll say, no, I don't know. I have no idea. I don't know what I'm allergic to. Okay, so then what I tell them, I says, look at the plant life around where you work and around where you live, and take a look at it. Because I went to this really interesting class at one of the College of Allergy classes, and what it is that what he was talking about is that when you go ahead, you look at what the plant life is, and what you have to do is see whether or not it's flowering. So in other words, they can say, well, look at the plant life at where you work or at your home. Are any of them blooming? Do you see any flowers? Because if you see them and your eyes are miserable, that means you're allergic to that plant.
That's a great tip. I mean, now, how much do you feel like if they don't know that you should send them for an allergy panel beyond that?
All right. So, okay. So this is going back. I mean, we were talking about before we are offline, we're talking about contact lenses. So I had this patient who was referred. This was like a phone call. I did a phone call. Uh, I didn't actually see the patient. I did a phone call with him, and they were referred because they're out of the area, and I was doing it as a favor as a friend. But anyway, what they were saying is that they were having contact lens dryness problems. And then they sent me a picture of the lenses they were using. So first thing I'm thinking about, okay, are you using daily disposables? Yeah, they're using daily disposables. In fact, they're using Total One, which is very, very comfortable. So I'm going, okay, you're using Total One. What other things have they treated? Well, the doctor can't find anything. I mean, I've tried every single drop known to man, every single drug, every single dry eye drug, all these things, nothing work. I can't wear my contacts for longer than 4 hours, and they start bothering me and everything like that. And I said, do your eyes itch? They go, oh yeah, they do. Do you have a runny nose? Oh yeah, I have a lot of runny nose. Do you have dogs and cats? Do they sleep in your? Oh yeah. My dog, yeah, I just love my dog. Yeah, they sleep in my bed. So I'm going, have you ever had a history of allergy? And she said, oh, absolutely yes. In fact, in the past, she went ahead and she had an allergy workup, and she was going through the shots. So she had shots, but she goes, it was many, many years ago. And I says, well, I also had shots too, but what it is I feel like I may need them again, because what happens is the shots over time, the pollen changes, the atmosphere changes, that we're re-allergic to different things. So what I suggested to her is that the problem is that I don't think that I mean, the eye doctors, as typically what we do is that we're just chasing after the ocular problems. But I think your root cause is allergy, because she says, yeah, she gets runny nose all the time, and she's got miserable. And I go, the last time you were tested, what did they? Oh, I was allergic to everything. I'm going, well, I would really, really strongly suggest that what you should do is have an allergy workup, and then perhaps going through immunotherapy. And I myself, after learning all this about allergies and everything like that, I was tested. I found out I was more or less allergic to everything. And I had went through, shots for 5 years, immunotherapy for 5 years. And what I noticed is that my dry eyes and my allergies just kind of disappeared after that. I mean, they were very, very greatly reduced. So, that is a classic case where, that was the root cause causing all of her problems. And if that gets treated, what I strongly believe is that I told her, I said, I think your contact lens problems are probably going to either go away or get a lot better. So, get back to me, after you go through all that, and then we can talk about your contact lenses.
I had that same experience. I had gotten allergy testing years ago, and I was sitting in the waiting room with the other few patients that had gotten their panels done. And I'm looking at my forearm, which looked like literally I got attacked by about 70 mosquitoes. And then I'm looking at the guy beside me, and his arm was completely void of any bumps. And I thought, like, oh boy, I'm really going to have trouble here. So I found out I was allergic to everything alive, pretty much. But I did sublingual therapy, so it was like similar to the shots, but I did it under my tongue. I don't know. I mean, it did really help. It did really help. I mean, when I was a teenager, I had such bad ocular allergies that my eyes would swell during ragweed season. I would literally have cold compresses, and I made the joke that Patanol wasn't around, but it really was. So my mom just didn't know about ocular allergy drops. So I was suffering for no good reason. Um, it did make a big difference. We did do allergy testing in one of the practices I worked in, using that same, the forearm test. And I found it to be very helpful, especially for patients. I had patients that just started themselves on some major oral antihistamines like Allegra and different things that were really compounding their ocular symptoms. And we found out they weren't really allergic to anything. So once we got them off that medication, it really helped us gain better control of their ocular surface symptoms.
So was the where you were working at, were they allergists that were doing the allergy
No,
testing?
it was it was that Dr. RX that was around many, years ago, where it was in an ophthalmology practice and you could do the allergy testing in office.
Yeah, so the allergists absolutely hate that.
I can imagine. It's sort of like us hating the retina exam in the primary care office for diabetes.
What they say is that what happens is that because if you notice that after you do the immunotherapy, after you get the shots, and they want you to sit there for a half an hour or an hour or whatever it is, in case you go into anaphylactic shock, so they can go ahead and treat it. So what they say is that when they do the immunotherapy under, let's say, by remote, or let's say, not under the guidance of an allergist, they deliberately, when they do the immunotherapy, they deliberately give you doses that are lower because they don't want the patient to go into anaphylactic shots. So what the thing is that the criticism that they have is that the outcomes are not as great or not as good because they're not titrating the amount of immunotherapy.
So we used it more as diagnostic. I never prescribed the treatment for a patient, but I can definitely appreciate that. And now I don't have access to that. So I like what you said about what's blooming. I think that's a great tip with flowering plants. Um, and just if they know that they have seasonal allergies, oftentimes patients just also blame everything on allergy, everything. So it's sometimes hard to know what, really is allergy.
Yeah, yeah. So yeah, it's kind of interesting, but that's yeah. So if you ask the patient, a lot of times they have no idea, but that's one way of figuring it out. In fact, if you take a look, it's one of the government sites. What they do is that they have cataloged every single plant in the United States. And what they've done is that they've not only cataloged it, but what they've done is that they've shown it there. I think it's plants.com. I'm not sure what the site is. If you can ask me later or if you're interested. But what it is that you can actually look at any specific county, and then you could see which kind of plants that are in that particular county. So if you're able to find that, let's say if the patient, you look on pollen.com and then you see, what the patients, a lot of times they'll tell you, what kind of, like it's trees, grasses, or whatever it is that they're allergic to, that there's high pollen counts. Patient comes in and they say, oh, well, you have high pollen counts. The trees are blooming right now. Well, you can actually look at their county, ask them where they're from, look at the county and find out what kind of trees are there. You can do detective work as to what to expect from different locations, because as you well know, pollen is location based, it's environmental.
Whenever I'm talking to a, dry eye or allergy patient, I'm always saying like, it's not one thing. It's never one thing that's really like causing it. It's like a little meibomian gland dysfunction. It's a little Demodex. It's a little blepharitis. It's a little allergies. And I think this is a good lesson to have us remember to not overlook allergies and how much of a role they can play in our dry eye patients. We're always talking dry eye, but there sounds to be like such, and there is such an overlap between those two things. So I think this is a good refresher on thinking about allergy, even if they're not itchy.
Exactly. Absolutely right. There's a test and a questionnaire that Leslie's familiar with. We call it the TOS, and that's the Total Ocular Symptom Score. And there's 4 different domains for that. One of them is itch. The other one is swelling. The other one is tearing, and the other one's redness. So, allergy in terms of ocular allergy composes of those 3 major categories, or 4 major categories. It's not just all about itch.
Well, I was just going to say thanks so much to Milt for imparting his wisdom, and exciting that you are a fellow in the Allergy Society. What did you call that? American Academy of Allergy?
American College of Allergy, Asthma,
This
and
is another
Immunology.
title I wasn't aware of. So congratulations on that. And it's nice that you can kind of bring some of that information to us in the eyes. So we thank you so much for your time.
Thank you very much for inviting me.
And now for the To The Point wrap-up. When managing dry eye, remember there is much overlap with ocular allergies. Some common symptoms are itching, watering, and redness. It's okay to combine therapies for these patients using antihistamine topical medications in addition to your foundational dry eye therapies. But targeting both disease states will achieve your best outcomes.